Chairman, ladies and gentlemen, first I will thank again Professor Osni and course directors to give me the privilege to be here to speak about the endovascular treatment of chronic type B dissection in patients with aneurysmal dilatation. These are my disclosure regarding this topic. And Germano reported that in the residual dissected aorta, we have a moderate to accelerated aortic growth. And if you look to the literature, the 1 year and 5 years risk of aneurysm degeneration come from 27.5% to 73%. If you look to this recent paper regarding the surgical treatment, about 217 patients, the conclusion of this paper are that we have a good result, but this is a more invasive approach and we need a specialized aortic center. According with the perioperative treatment of thoracoabdominal aortic aneurysm with fenestrated branch endograft and the long-term result of the paper presented by different centers, and we have to discuss if branch fenestrated device have a role in chronic type B aortic dissection. The first paper was published by the group of Eric Verhoeven and Piotr Kasperczak in 2012, and the results are absolutely good in 6 patients. They stressed that in this patient we need some technical support regarding the role of fenestrated endograft if compared with branch, the role of the perforation of the lamella, and the high risk of endoleak type 2. Recently, they published the same groups, 71 patients, the results of, after a median interval from the primary aortic dissection of 45, and they stress the role of prevention of spinal cord ischemia, the percentage of previous aortic procedures, and the high percentage of custom-made endograft and not of the shelf endograft for treatment of these patients. They reported the percentage of spinal cord ischemia of 15.5%. The majority were temporary spinal cord ischemia. And they reported again a high percentage of the reintervention in the follow-up of these patients with very good results regarding survival and target visual patency. The main reason of this freedom from reintervention percentage was the endoleak, that in the majority of cases are endoleak type 1B according to the target vessel and the iliac vessels. The conclusion of this paper was that in chronic aortic dissection, fever and beaver is feasible, but we have a significant reintervention rate. According with our results in the treatment of thoracoabdominal aortic aneurysm that we recently published, we started with our approach in endovascular treatment even in patients with post-dissection thoracoabdominal aortic aneurysm. And I show you the last case that we treated in female 66 years old with post-dissection thoracoabdominal aortic aneurysm with celiac trunk, superior mesenteric artery in the right renal artery from the true lumen and the left renal artery at the level of the true and false lumen at the level of a tear. We treated these patients with custom-made endograft with preloaded guide wire, and we did a revascularization of the 4 visceral vessels, 2 renals, SMA, and the celiac trunk. We used in these patients inverted limb for the bifurcated endograft, and we closed the re-entry tear in the external iliac artery with a Viaman. This was the final result at the level of visceral vessels, at the level of celiac trunk, SMA, and both renal arteries. And the final postoperative course was uneventful with no spinal cord ischemia, no splanchnic ischemia, and the patient was discharged in 7th postoperative day. Recently, the group of Debut and Thilo Kolber reported 20 patients, and they stressed some technical point. Fenestration is correct to use in target vessel originated from the true lumen, branched in case of target vessel originated from false lumen, and when compromise was necessary to choose a distal landing zone at the distal dissected vessel, embolization of false lumen with plug, coil, or glue. They stressed again, like the case that Stefano Long presented, a fantastic case that he did yesterday, that there is a high percentage of IBD in the treatment of these patients, 35% in the experience of the Hamburg group. The other very important point that was stressed with this paper was that at the end of follow-up, after 1 year, they had 92% of false lumen thrombosis. And then, according with the fantastic lecture of Germano, this is a very important point to stress because we have a good result in the follow-up regarding false lumen thrombosis. Then, ladies and gentlemen, in conclusion, we think that the fever and beaver for post-dissection thoracoabdominal aortic aneurysm is feasible with favorable aortic remodeling, with false lumen thrombosis and aneurysm regression. We need some technical aspects, we need some technical tips and tricks, the use of custom-made, the fenestration in target vessel that originate from the true lumen and branches from false lumen. We need preloaded wire and we need a staged procedure. We have to make attention regarding the percentage of intervention, and then in this patient we need a very straight follow-up in the history of the patients. Thank you very much for your kind attention.